How did you get involved as a researcher in studying psychedelics?
Yeah, that's a good question. As you may know, I was a professor of psychiatry and addiction in the Netherlands for 25, 30 years. And then there was the previous ICPR. And then in the preparation of that, Joost Breeksema asked me whether I could join them in the scientific committee to look at the scientific quality of the abstracts. So the field was relatively new to me, and then Joost and me, we immediately started to collect papers and made a special issue for the Dutch Journal of Psychiatry. So that was a start. It was basically Joost Breeksema. I'm sure you have interviewed him. He is such a nice person. He knows how to make people enthusiastic, and so I got into it. So I'm there only for the last three and a half years, and it's a very nice community. It's just a little less competitive than the academic world in general, and so it has become one of my major interests right now.
Some people say that psychedelics are one of the first new major innovations since the 70s in psychiatry. How do you see that?
Of course, it's not an innovation. It was there for a long time. It was sleepy. Like a lot of work was done in the 50s and 60s, and then the war on drugs started, and then not all the work, but most of the work stopped because the drugs. Better say, the medications weren't available anymore, and research was more or less banned. And so it is definitely a what some people call the renaissance of psychiatry, or maybe more specifically, there was, I think, a crisis in biological psychiatry. There were very few new drugs coming to the market. For depression, we had the TCAs, then the SSRIs, and the new SSRIs, but it was a lot of Me Too. It wasn't a lot of new. With antipsychotic medication, it was a little bit the same. It was dopamine antagonist, and there was a little new things with glutamate receptor medication, but altogether not a lot of new. I think one of the few areas where there was still some news going around was addiction. Now, don't believe me, because I'm an addiction psychiatrist. So, but there was still some development. There was definitely a need for a new, active, hopeful signal to the biological psychiatry. So it comes at the right moment, or maybe the moment was there because there was such a crisis in biological psychiatry.
Psychedelic treatment is a hybrid between talking therapy and psychopharmacological treatment. Can you explain why and how is it different from traditional forms of treatment?
Yeah, I think originally we were always thinking about talking therapy, and then came in the, say, 1950s came the real breakthrough of psychiatric medication. And then it seemed that there was almost a full change from talking to prescribing medication. But I think in general, the good psychiatrists were always combining medication with talking therapy, be it cognitive behavior therapy, or later on, of course, the therapies for personality disorders like dialectical behavior therapy and other ways of specific psychotherapies. The only thing is that it looked a little bit that there were two separate things that you did, and there wasn't a strong synergy. Maybe there was synergy, but we didn't think about the synergy between the pill and the medication. So I think this is the new thing, that we start to think that these two activities, on the biological level, on the psychological level, that there might be an interaction, and maybe the interaction is essential. And another thing is, of course, that with regard to these classic pharmacotherapies, the subjective experience outside of the core symptoms were not interesting. And now we start to see that maybe the subjective experience during the trip that people make might be essential for obtaining the effect of the psychedelics and the psychedelic assisted therapy. So I think that we do look at it differently, and it's an interesting way. And I think we should start to look back at our other pharmacotherapies and see whether we could do similar things with these therapies. Look at, for example, we give medication, we do anti-craving, we do cue exposure therapy in addiction treatment. We never talked about what is your medication do with your craving. We just looked whether we're still using. But maybe we should ask a little bit more. How do they change your craving? What kind of craving is being changed if you take that medication? Is it a craving for the high, or is it a craving for getting rid of the low? We never talk about that. So maybe we start to learn from this psychedelic research that we should actually also ask what these medications in subjective experiences do to the patient.
What is the neurobiological mechanism that explains why psychedelics are so effective in treatment?
Yeah, that's different. It depends on what kind of psychedelics, whether you talk about the classic psychedelics such as LSD and psilocybin. There it's quite clear it's the 5-HT2A receptor agonist working that is doing the job mainly. If you talk about ketamine, which is an atypical psychedelic, then it's definitely, it reacts to the NMDA receptor in the glutamate system. And if you think about MDMA, it's a release of, mainly release of serotonin. So on the biological level, and the neurotransmitter level, they're quite different. Now, the interesting thing is, of course, is why do these different psychedelics not only work in one mental disorder, but that they seem to do work in different mental disorders. And another interesting issue is, why do these very different substances, in terms of their neurobiology, seem to do more or less the same thing? Like it seems that psilocybin is working against depression, but also ketamine, with a completely different mechanism of action, is working against depression. So people have been looking for underlying explanations. One explanation could, for example, be that we have all these different disorders in psychiatry. Maybe that is an artifact. Maybe a lot of these disorders have one underlying shared mechanism. There's always been talking in psychology about the P factor, the psychopathology factor, the general factor that you find in many disorders. For example, what the idea is about psychedelics, that they can reduce the strict organization in the brain, the compulsivity, the compulsive thinking, as you see it traditionally in obsessive-compulsive disorder. But the compulsive feeling and thinking in depression, like ruminating all the time, walking the same cognitive, emotional path in your brain. The compulsive feeling of craving, always thinking about, I want to have the drug, even if I don't enjoy it so much anymore. The compulsive behavior in PTSD patients who avoid certain situations and keep repeating dreams and nightmares. So these are engraved paths in the brain. And so some people say on a biological level, they say what you see in the brain is a disturbance of the normal connections between the different parts of the brain. And there is a situation of entropy, of chaos. And so all these fixed pathways, they're mixed up a little bit. And so maybe that is what the general idea is behind why these medications work for all kinds of different disorders, because they shake up the existing very strict, inflexible ways of thinking and behaving and experiencing. So that could be one of the underlying, what was in the past recognized as the psychopathology factor, the P factor. That could be some of the explanation. There might also be other explanation that they may all do something like makes the brain on a biological more plastic, the plasticity increase. And so what happens is the brain is more willing, has a higher willingness to change under psychotherapy. So normally psychotherapy do, but there is maybe resistance in the brain to have changes. And so with taking this medication, before you do the psychotherapy, you might make the brain more malleable And that is the way it works. So there's interesting, very basic science done with these medications to see that that really increases the number of synapses in the brain. So that might be another explanation, but we're not sure about the definitive answer to what is causing these kind of effects.
Psychedelics don't work for everyone. Do we have any idea for whom they work and for whom they don't work?
No. Just as with all the medications that we have right now in psychiatry, we know that they work. We know that they work for sometimes a small part of the population, sometimes a little bit bigger part of the population. We're looking for that. It's the holy grail in psychiatry, that is looking for personalized medicine. What works for whom in what kind of condition. So these are I think the most promising part there is the genetics. People with different genetic makeups, do they have different responders to our medication if they have a certain disorder? And there are promising findings there. I know, for example, that if you want to have a patient with alcohol dependence and you provide him with naltrexone, he is more likely to respond to naltrexone if he is a male, if he is interested in very sweet tasting substances. And probably that is related to a specific variation of the mu-opiate receptor gene. So we know that, and if you give it to certain people with a certain variation of this mu-opiate receptor gene, you have a higher probability that they will respond. For most of the medication, we don't know that, and that's the same, I think, for psychedelics at this moment. And so we're definitely going to search for that. I think that people do use some ideas. And maybe one of the things that what I have people heard saying, that people have very high expectations, maybe they're not the best candidates for a positive response. But I'm not sure that it's well studied, so it's really the next step. And maybe it's a long process to learn to know for whom is this medication the best. The next question, of course, becomes what to do with patients who don't respond to this, to one of the psychedelics, because nowadays psychedelics are prescribed most of the time as a last treatment option, which means that you're dealing with patients that are in a very vulnerable situation. So you're offering the last treatment option. So what if it doesn't work? And if you see the studies in PTSD with MDMA, it's about 50-60% people who respond to it, but also 40% who don't respond. So this was their last treatment option. So I think we should be very careful and very well aware of the dramatic influence that might have, and you have to be careful in preventing suicide in these patients. So it's a very serious question. And what comes after this last option? Maybe another last option. Maybe if you didn't do well on MDMA, maybe psilocybin might be your next option. Or with the ketamine, I think now there's a real question with treatment-resistant patients. What is the sequence? First of all, maybe people start with psychotherapy, then psychotherapy with one of the medications, tricyclic antidepressant or SSRI, and then what to do next? Do we do next electroshock therapy, ECT, or do we first do ketamine? Or first ketamine and then electroshock therapy? So I think these are very important questions that come up right now.
Do psychedelics have a potential to treat addiction?
Absolutely. There's quite some studies done now. The funny thing is that actually in the 50s and 60s, I think the best studies at that time were not done in patients with what they then called neurosis, which now we probably call anxiety and depressive disorders, but they were done with people who were treated for alcoholism, as it was called at that time. And there's actually a very nice meta-analysis study that summarized the results of 6 randomized controlled trials of one dose of LSD in patients with alcoholism. Randomized controlled trials in the 50s, which was very new at that time. And they show a very positive effect of LSD. Now, we're not using LSD so much anymore because it has a very, very long time of acting. So, but now there are good studies with psilocybin, with ketamine, and they show very much promising. And the interesting thing is, and that has been a change in the addiction field, In the 1950s or 60s, people come to the addiction treatment settings, they had either an alcohol problem or a drug problem. That's not what we see anymore. Now we see only patients who they're addicted to many drugs at the same time. They're polydrug addicts. In addition, they have a lot of additional psychiatric disorders, PTSD, depression. And so what the promise is for psychedelics in the treatment of patients with addiction now is that we can actually address the fact that they have that they have polydrug abuse, and they have other comorbid disorders. And maybe so with this one medication, or I should say psychedelic assisted treatment, we can actually cover both the different drugs that they use and the fact that they often have post-traumatic stress comorbidity or other comorbidities. So I think there's a lot of promise there. The studies look very promising. There is no phase 3 studies yet, but they're underway. So within, I would say, anywhere between 3 and 5 years, we will have a registered medication there.
Clinical treatment has very strict rules and limitations, but people have been using psychedelics in other non-medical settings, in groups, in the nature. Do you think that we can combine those methods with clinical treatment?
I would say we can learn from each other, but I would be careful because I think what are the experiences now in retreats and celebration settings? Basically, I wouldn't be very afraid if healthy people go there. I mean, mentally healthy people. They have their own resilience, and even if there is problems during the trips that they have, and if there is at least some guidance, I don't think it's a very dangerous situation. That might be quite different if people with very serious mental disorders go to these same retreats, treated by the same people who have less or no experience and are not trained to deal with serious mental decompensations. I think there is really a risk, and that's one of the risks of the hype that we have now about the effectiveness of psychedelics in the treatment of patients, that these patients who cannot reach out to these psychedelic treatment in the regular mental health system will go to these alternative, sometimes very commercial retreats. And there might be serious risks involved. So I think we can learn from each other, but we should be careful not to send our serious, vulnerable people to retreats where there's no professional guidance.
Some people say that we move too fast and there is a risk of backlash. How do you see that risk?
It's almost a general law that there is something like in a new social introduction, there will be a hype. And I think we're a little bit over the hype, and the issue with the advisory committee of the FDA is an indication that there is a group that says, okay, wait a second, we're enthusiastic, but let's look at all the bolts and nuts. Is everything okay, and don't we have to slow down a little bit? So I think we're over the hype, we're getting into the phase where it's we're becoming more critical, and I think there's nothing wrong with that. At the same time, we shouldn't be too hesitant that the train stops. So I think they're absolutely right that they call for being careful, being critical, but it shouldn't stop us from making progress.
You talked about retreats. As far as I know, there are many retreats in the Netherlands. How are they regulated?
They're generally not regulated. They take place outside of the organized and regular treatment system. So as long as they don't use illicit products, they're actually also not controlled by the legal system. And so what you see in the Netherlands, that the retreats, what they offer is they offer, for example, no psilocybin. They offer also no magic mushrooms. They offer mushrooms that grow under the ground, and so because they're legal, so they offer only legal substances in the treatment. The same you see with the MDMA treatment. They don't offer MDMA assisted treatment. They offer what they call MDMA-like assisted treatment, where person don't know what they get. I'm not always sure that the treatment system knows what kind of MDMA-like medication they use. And most of the time they tell you that it's a medication that is similar or the same effects of MDMA, but I'm not sure that they know and that it's actually known. So there is very little control. And there was just a report yesterday sent to the Minister of Health by a state committee. They say that we have to be careful. We don't say that the police should go after them, but we should be careful, and that we definitely should start a hotline where people can complain about bad experiences during their visit to retreats, in order just to get a little bit more of a view on what's going on in that often very commercialized circuit.
What is the situation with MDMA treatment in the Netherlands?
Our committee decided that irrespective of what goes on in America, we should set up a large, what we call naturalistic study, that people can apply for MDMA-assisted therapy if they have PTSD, and they will be treated with, but they will do that in the context of a naturalistic study, meaning that everybody that is coming to the study will get that treatment, but we will do some registration of you. We will ask you about your PTSD symptoms, your depression symptoms when you come in, 6 weeks later, 6 months later, and 12 months later, and we'll record these kind of data. And so we will know at the end, after 3-4 years, we know we'll probably have 500 patients that have gotten the therapy, what the options are and what the results are in this naturalistic study. You might call it already a phase 4 study, which you often see after medication is registered. And we hope that in these 5 years that we run this naturalistic study, that there will be a registration coming up and that we can just provide the medication according to the normal standard procedures.
The costs of psychedelic treatment are very high. How can we make sure that they are accessible to less wealthy people as well?
In the Netherlands, there's only one way. You can only do it if it's accessible for anybody with any kind of income. There is no way that you can do it. Like in Australia, you actually have to pay yourself for the psychotherapy. There's no way that we're going to do that in the Netherlands, because there is here still the idea of solidarity. Health treatments are for all people, and they should be accessible for all people with all kinds of income. So I think that will not be the problem. It is expensive. At the same time, I think we have to look for ways to make it less expensive. For example, we now do individual integration sessions. We might well do group therapy sessions for integration, which may become much cheaper by that. We're not going to change the sessions themselves. We make sure that there's always 2 people available, because you know the stories about abuse, which is terrible. It happens in all kinds of treatment sessions. It happens in physiotherapy sessions. It helps in. It occurs in normal psychiatric treatment setting. It happens, of course, in the gynecology field. But these people are in a changed sense of consciousness, and so we have to be very careful. So we're not going to be cheap on that. The MDMA sessions will be with 2 therapists. To be safe, but the integration sessions, we might think about making them much cheaper by doing them in groups. Maybe they're also more effective in groups, that people can experience from other patients. So we have to look at these issues. They're serious issues. Don't forget that people who have an ongoing PTSD, they make use of quite a lot of other services, both psychiatric service and physical health services. So there is also a price to that. But it's an important issue. Yeah.
How do you see the role of harm reduction in the psychedelic field?
I'm a member of a harm reduction organization, Mainline, in the Netherlands. And we see some very serious good issues there. One is informing people in the right way, telling them what these drugs, these medications can do, making clear to have a proper expectancy management. some people think that this is a wonder drug. It's a magic bullet. And we know that there is, as I told, there is maybe 40, 50, 60% of people who respond very well, and there's others who don't respond well. There's people who become more anxious, and so we have to deal with it. So I think they play an important role in accurate information. As I also said, there will be also negative experience with these retreats. And I think they would be very good, and they have people who could do that, to have a helpline or a hotline and a helpline for people with negative experiences. So to see how they guide them outside of this negative experience. Harm reduction in the sense that reduce the harms done by improper practices. Maybe they can also reduce the harm by proper practices, because there might also be people who are unhappy. And then, of course, there is also something like people who cannot be helped by this. They still need some support. And so harm reduction people are definitely also in the addiction field. They're very well equipped to still deal with people who can't stop with their addiction, but still find a way of living that is better than before. So I think there is still space for harm reduction there also.
How do you see the future of psychedelics? Will they be part of the mainstream medical care? And do they have a room outside of the medical realm? Yeah,
there's very good indications that they're going to be part of medicine, psychiatry, general standards psychiatry. If you see where the studies are published, they're not published in journals for alternative medicine. They're published in a New English Journal of Medicine, they're published in Nature Medicine, they're published in the mainstream highest impact factors of medicine. There is a platform in the Netherlands of psychiatrists within the Dutch Association of Psychiatry, and there is 300 people who are connected to that platform in a very short period. So you see, it seems to be attaching normal psychiatrists, not people who are very special, and so it will be definitely a standard part of psychiatry. If all these promising results hold up, it will be part of normal medicine. Now, whether it will be a separate group, it depends a little bit on what the requirements, for example, will be about. There's a discussion about whether, if you want to be a psychedelic therapist, whether you should have used the psychedelics yourself. And there is a big group that says that is absolutely needed. And there will be psychiatrists who say it's not for me. So that would be a separate group then. And there will also be a group that says that's perfect. I have no answer. I think that most people now agree that you should have some experience yourself with these medications or with these drugs. So that could be a little bit of a division between groups. Although that might also change. If people stop looking at these things like drugs, but see it as a therapeutic experience, like in the psychiatric training, you do also learning therapy, which I've been on the couch for 4 years, which is a bad trip for me. Being on the couch with a psychoanalyst who's not talking to you. It's an effective neglect psychedelic experience, so it's a negative trip. So maybe we get more positive trips before we become a psychiatrist.